All right. Hello, everyone. My name is Dan Gillen, and I am the Transformation Advisor at the Health Center Association of Nebraska. Welcome to our Lunch and Learn with Depression Remission Best Practices. We'll have a kind of a brief presentation today from Tracey with the Health Partners of Western Ohio. She is the Chief Behavioral Health Officer at the FQHC there in Ohio. Before we pass it over to Tracey, I did want to just highlight the UDS measure that we're really focusing on today. So from table 6B for the depression remission measure, the performance measure is the percentage of patients 12 years of age and older with a diagnosis of major depression or dysthymia who reached remission 12 months after a positive screening for depression. The denominator in that measure is going to be patients 12 years of age or older with a provider visit where a diagnosis of major depression or dysthymia was documented and having a PHQ-9 or a PHQ-A score greater than 9 occurring in the index period. And then your numerator for this measure is going to be patients who achieved remission at 12 months as demonstrated by a PHQ-9 or PHQ-A score of less than 5. So historically, for many health centers, this has been a difficult measure to improve performance numbers on. And so we're excited to have Tracey here today to share some of the promising practices that they've done over the past year or so. I'm going to pass it over to Tracey. Afterwards, we can have a little question and answer session. And then when you exit the meeting, you should receive a link to do a brief survey on our presentation today. So thank you everyone for joining. And Tracey, I'll turn it over to you.
Thank you, Dan. I'm going to try to share my screen. I am not the most tech savvy, so you all let me know if it works. Are we good?
We got it.
Okay. Can you see my notes page or just my?
Just the main slide.
Awesome. Okay. Well, it's afternoon for me, so I'm in Ohio. We're in Eastern time, so you guys are probably all eating lunch. That's great. I'm Tracey Hueve. Like Dan said, I'm a social worker. I've been in the field for more than 15 years. I earned my bachelor's and my master's degree in social work at The Ohio State University in Columbus, Ohio. I was a behavioral health provider at Health Partners for several years, and then I entered the leadership space in 2020. So I'm going to talk today about depression remission. This is a measure we have given a lot of attention to since 2021, and we have seen a lot of progress over the past few years with our outcomes related to our own refinement of the process. So before we dive all the way in, I'm going to talk just a little bit about our journey, some of the things we have in place that have helped us be more successful with this measure before we even kind of get to the measure. So we have integrated care. So all of our health centers are integrated. Every single site and every team has at least one behavioral health provider. So all of our teams are either one-to-one, one medical provider to one behavioral health provider, or one-to-two, where there would be two medical providers for each behavioral health provider. We huddle in the morning, so we sit with the team. We really travel through the schedule together. So our model does not have a behavioral health provider in an office or accepting referrals. We both see the patients on the medical provider schedule. We see patients, we each have our own lens, but we're going to come together to give really quality, really well-rounded care. And I'll say exactly that to patients. So we might look at the schedule in the morning and we have our morning huddle, and there might not be patients on that schedule that the behavioral health provider anticipates seeing. But we're not a separate service that's going to get a consult. So if we are adding patients that we're going to see throughout the day, it's really just a request from the peer sitting beside us. So that might be an LPN, or it might be a nurse practitioner, and they'll say, hey, there's something concerning me about this person. Would you mind to see them as well? Another thing that helps us in this measure is that our medical providers prescribe medication for mental health. I'm not sure if that's everybody's practice, but that really reduces referrals out of the organization the majority of the time. So, of course, there's situations that are going to be better managed by psychiatry, but largely we try to manage as many needs as we can in our health center. And I think these things really being in place has definitely enabled us to be successful with depression screening, follow-up, and remission. So our best practice, along with our integrated care model, we follow our own kind of internal best practice to inform how we see patients. So we complete a PHQ-9 or, like Dan said, a PHQ-A for that age 12 to 17 range. We'll do a PHQ every 90 days. So I know that the measure is really once a year, but we do it a lot more frequently than that. We also complete a GAD-7 every 90 days as well. So we have paired those two screenings for all patients age 12 and up. That's really created a culture for us where we're always kind of keeping a pulse on their mental health. And it's something we talk about with all patients really all the time. We also, the second part of that best practice is that if we have a patient with a medication change, that's usually also paired with a positive screening score. Our behavioral health providers have really close follow-up with them. So we're making a phone call to patients 1 to 2 days after a visit. We're going to call them again about a week after, and then we're going to follow up in the office with behavioral health and medical provider about 2 to 3 weeks later. We also follow up in the office outside of that positive screening. So those patients that are really getting kind of put into your denominator, patients with a diagnosis and patients that have a score of greater than 10, we're not really getting nuanced in that in our best practice. That's going to kind of fall into place if we take care of all patients this way. So we follow up in the office then at month 2, 4, 6, 9, and 12. In practice, that looks a lot more fluid as patients' mood evolves and as additional changes are made. So I would say that the monthly intervals later on are a lot more fluid than this concrete. So what we've seen, we have had a definite increase in rapport and relationship with our patients. The more we talk to them, the more we're connecting with them, the more open they are, the more we know about what their symptoms are, their side effects, the more we really get an idea of what their experience is rather than just in the office every 3 months. We have been able to troubleshoot issues. So previously, some providers, if they made a medication change and we had a patient that was depressed, the score on the screening was 10 plus, the provider would schedule them maybe 3 weeks later to follow up, or maybe 3 months later. There wasn't really much structure, and providers were really handling that differently. So there wasn't really a concrete window. So what we would have happen is a patient, has a PHQ score of 20. We've added a medication to help them, and we said, hey, see you in 3 months. And so 3 months later, a patient, hopefully they would come back, but they would come and they'd say, hey, I did not like that medication. I stopped taking it. Well, why did you stop taking it? Oh, I felt terrible. What, can you tell me a little bit more about that? Oh, I don't know. I can't remember, but I just know I felt really terrible. I'm never taking that again. And so we've lost all this time. So now 3 months later, a patient is not feeling any better and they've been suffering the way that they had before ever adding an intervention. And now we've ruled out a medication that maybe would have been a really good fit and really beneficial. And there were just some common side effects that we really could have done some troubleshooting around. Other times people would come 3 months later and they couldn't afford the medication. They went to the pharmacy, they couldn't afford it, so they never picked it up. Of course, we always say, call if you have any trouble, but it's really difficult to pick up the phone and call somebody to tell them you're having a hard time, especially when you're increasingly depressed. So those increased phone calls have really helped relationship building, but they've also helped us find all kinds of concerns along the way, rather than kind of pushing them down the road. For us, we definitely see that with psychiatry. If we send a patient out, they have a really long wait time to get in, and then when they do, it's nearly always a 3-month follow-up. So hopefully that looks different for you guys, but our experience was we really had to keep patients much, much closer to be able to better care for them. We've seen an improvement in symptoms. The more connected we are and the more conversation there is, and the more we understand what's going on, the more we're able to help. And so we've also seen not only improvement in patients and their symptoms and their quality of life, but we've seen our remission measure also has jumped up quite a bit. So I'm not sure if you guys have like a data monitoring platform. We use Azara. And so this is sort of a screenshot of what our measure looks like. So of course that measure grows throughout the year, the more patients get to that follow-up period. We always call it a window, like a follow-up window. And I know Dan kind of alluded to that. We're checking on that PHQ 12 months later. To do that date replication is going to be impossible. So we get 2 months on either side of that date. So After that positive PHQ, from 10 to 14 months later, we want to see an improvement in that PHQ score. So as the year goes on and as that time period happens for all of the patients that are in your denominator, that's going to continue to get better throughout the year. So some measures you can look and you're performing, kind of average as you would expect. January 15th and December 15th, maybe wouldn't look that different. Whereas depression remission, hopefully, that that's going to get better as the year goes on. So we've seen a lot of growth despite, some changes that HRSA has made to how they measure this. We've tried to kind of pivot and offered some different options for our teams. So the process for us, we have really given ownership to the behavioral health providers to focus on this measure. Most measures are really managed by our medical provider and our support staff. So this is one that behavioral health can really be invested in. With our best practice that we just talked about, we really try to keep patients very engaged in their care. So they're coming in really regularly. They know us, we know them. We complete PHQs so frequently, so we're really likely to capture that PHQ on the patient. If we're doing it every 3 months and we have a 4-month window, if they're coming in the office, we're capturing the PHQ. Is it going to always be remission? Maybe not, but we're definitely keeping a pulse on that. They're going to be due in that window, but that's really just if they're coming into the office. So we use our data management to generate a list of patients that are in the measure. We have sent out, it's difficult for us to get even access to a list at the beginning of the year. That was like our biggest hurdle up front. So we figured out how to kind of get that master list. We sent it out at the beginning of the year. We used to send it monthly to keep it kind of top of mind as the measure changes month to month. In 2024, we sent out a list earlier than we ever had. We were so proud of ourselves. This is going to be our best year yet. I went on a maternity leave, so it really was not on their radar for 3 whole months. And I came back and we were performing worse than we had the year before. So I think really keeping that top of mind for providers to be in touch with patients and be tuned into that, that is really critical too. Your medical providers get kind of hammered with data all of the time about how they're performing. This is the one thing for behavioral health providers to really monitor. So we have a pre-visit planning tool, and we've activated an alert to let us know when the patients are in that follow-up window. This alert actually fires even if they're not in the window at the day of their visit. So it's going to be on their pre-visit planning if their window is going to open within 30 days. So even if it's not open today, we definitely want to check in and see how they're doing. We want to open a task for ourselves to kind of remind us to follow up with them when the window does open. But if today their PHQ is 21, it doesn't matter if it's within the window or not. They need help. They need extra care and extra support and extra interventions. Our flag also will be active if they have had a window that's closed over the last 12 months. So again, this isn't going to make a difference to your measure today, but if the patient was still struggling, they're going to be back in your measure for next year, or they're going to be back in your measure again. So continuing that engagement with the patient. We know that they were struggling. We know they had a PHQ of 10 plus, so we know that they need a behavioral health contact. For us, it's really more related to patient care and outcomes and not as much focused on the measure. I think that's actually a good kind of pause to just kind of talk about our philosophy around the measure. This measure is super nuanced. I'm sure it's frustrating to many of us. So you only have 4 months to capture this screening, and the score you have to reach is really lofty for some patients. So I've really taken the approach with my team that it's, I'll refer to it as this is an effort measure for me. I want to see that you're connecting with patients. I want to see you're scheduling them, making attempts to reach them. If we have helped a patient go from a PHQ score of 25 and now they're at a 10, they haven't met the measure, but their lives are definitely better. And that is a huge win. That's a very, very significant. So we definitely want to still celebrate that. If their window closed last week and they're in the office, we're still going to check in. We're going to still see how they're doing. It's not going to move them to the numerator, but they know we care, and that's what this is really all about for us. So helping people feel connected, feel like someone cares about them, and the goal is really to reduce their depressive symptoms. So I really do reiterate that with our teams all the time. And I also say we don't get to pick the parameters of the measure, but there has to be some parameters for it to be measurable. So it's not what maybe we would have picked, but it's good to have some thermometer for what we're doing. It's good to have a pause point in care to measure our progress. And if we focus on the patient and get out of the weeds, then we're all going to be better, us and our patients. Easier said than done, because I can be guilty of getting all the way in the weeds and trying to, tackle this. I'm a little competitive with that, but all, with patient mission, at the front of it. So another thing we've done is we created task types in our electronic health record. So we'll open a task for a patient if we know they have an appointment coming up. That's going to remind us to call patients. We might capture a PHQ on the phone, or we might get them scheduled to see a provider, but that contact point really empowers us to know how to reach them and how to connect with them. It's really helpful, especially for patients that are not coming through the office. If they're coming through the building, we're going to get a PHQ. It's for the patients we've sort of lost to care. Exactly that experience I talked about up front. If you have a patient and you say, hey, we're going to add this medication, see you in 3 months, and they couldn't afford it, couldn't pick it up, didn't have transportation to get to the pharmacy, took it, had horrible side effects, stopped taking it, suffered through the side effects for a month and never picked up a refill. All of those many things is really going to increase your likelihood that they're not coming back. And so then you aren't going to catch them in the office. So this has been really, really helpful for those patients that are sort of lost to care and lost to follow up. We all have no shows, right? So we all have missed appointments, changed phone numbers, things like that. So this keeps those patients on our radar to make sure that if they don't come in, that we're still checking in with them. Honestly, like very genuinely, patients love to hear from us. So they are super touched when we call to check in, especially outside of a visit. Naturally, you're going to have those patients that are not interested or don't answer, but the ones that you can connect with are blown away by this service. When we first rolled this out, I think I have a few minutes left, right, Dan? Am I doing okay? When we first kind of rolled this out, I was sort of the face of the measure, and I myself was overwhelmed. I'm like, we're trying to see patients and follow the medical providers and see as many people as we can to improve access. And now I have to make all these phone calls. We make medication changes all the time. I was very overwhelmed by the idea of it. And the very, very first call, I had a patient who had not even been seen by my team, happened to be kind of on our list, and I had never met her and hadn't been seen for 6 months and wasn't scheduled for another 6 months. So I picked up the phone and I gave her a call. I was like, hey, I feel like I'm cold calling, right? Hey, this is Tracey. I'm calling just to check on you. I know the last time you were seen, you really weren't feeling very well, and we're not going to see you for a little while. So I just wanted to check on you, make sure you were doing okay. Silence. I was like, this is going so bad. This is like all the things I was worried about. And then when she started speaking, she was like, I cannot believe you called me. Of all the times you could have called, I cannot believe you're calling me right now. I have goosebumps even just thinking about it. I was like, okay, kind of pivot a little bit. How are you doing? I'm terrible. I haven't taken a shower. I haven't left the house. I lost my job. I'm going to lose my housing. I'm so depressed I can't function. And I really, really cannot believe that of all the moments you just called me. So I said, hey, you don't need to take a shower to come in. We're going to get you in today. Really worked with her. She was profoundly depressed, had suicidal thoughts, plan, had intention to follow through. And so you really can't have an experience like that and not feel like this is exactly the right thing to do. We have more than 40 social workers at our federally qualified health center, and I would say just about every single one of them has reached out with a story just like that. Like, hey, we've been at this for a long time, but I just want you to know that what we're doing is still really important and it's definitely still making a difference. So it's definitely, our process was an uphill battle for having, providers having ownership of this. But they have all personally been touched by the process. And I think it's super fulfilling to connect with a patient like that and know that you are really, really making a difference, even outside of the day-to-day care you're providing. So we've been really proud of how we've performed, and we've also just been really proud of how we've taken care of patients.
Well,
That is all I
that was
have.
great. Thank you. I think we can open it up to questions, and we do have two questions in the chat. So I'll read them aloud just for the group, and then Tracy, if you want to share
Sure.
your answers. So we do have a question that says, if someone comes in multiple times in a 3-month window, do you do a PHQ-9 at every visit?
So if a PHQ is normal, like just for regular everyday patients, we really are just doing it 90 days. We're not going to be flagged to repeat that PHQ for a patient who's not on the remission list. If we have a patient that is on the remission list and they have that 4-month window, if we do a PHQ early and it's still elevated, we will repeat it throughout that window. Sometimes early in the conversation, that they're not in remission. And so, maybe it's a visit and you don't formally do a full PHQ, but in conversation, you're assessing their sleep and their mood and their energy and all of that. So you may pick up pretty early that it's definitely not 4 or less. 4 is really lofty, genuinely. So formally, yes, but in practice, maybe not 100% of the time. If I didn't answer your question, definitely let me know.
All right, next question is, are you having your staff complete the screenings with the patient in office, or do you send it to them before the appointment, like maybe on a patient portal?
So I can say our patient portal is not stellar. So we really honestly don't use our patient portal all that much. I personally have concerns. I know that a lot of agencies will do that where they'll send PHQs in the mail or through the portal. I have concerns about that just because I don't think we have the structure to know immediately if someone was positive for question 9. I think some agencies have worked around that by doing a PHQ 8. But we do ask that final 9th question, are you having any thoughts that you would be better off dead or thoughts of hurting yourself in some way? And so I always have concern that if someone answered that on paper and mailed it back to us or did it on a portal, like what's the alert process? We don't have that structure in place. So we do them face to face in the office. We will do them. Sometimes support staff does that. Sometimes our behavioral health provider does that. We also have behavioral health technicians, which will help with screenings and resource provision kind of happening in the background. So we have an in-person process. Now, for depression remission, we will sometimes place phone calls to patients, and then you can capture the PHQ outside of an encounter for this measure. It does not count outside of an encounter for depression screening. So whatever your process is, that might throw off your timing, but you can do them, and they will count for the measure outside of a billable qualified encounter.
Perfect. All right, we got more questions rolling in, so I'll just keep reading. Let's see. There was a question about the makeup of the staff. Are all your staff LISWs?
Yeah, so I don't know what staffing looks like in Nebraska. I'm assuming everybody on the call is in Nebraska. We do hire only independently licensed social workers. We really want our staff to function at the top of our license. So we don't have the structure in our model to offer supervision or things like that. So we really do stick to independently licensed social workers, and they are a hot commodity. It is difficult to staff right now. So if that's a hurdle you have faced, I feel you. But we haven't opted to use LSWs or lower, less independent license.
Another question was, do you use CHWs or community health workers for the process?
So that's probably consistent with our behavioral health technician. They are not licensed. We do just in-house training to do screenings. It depends. So if you're brand new, no, we want you to really be comfortable doing those screenings in person. You pick up a lot of, other cues. There are many times a patient will get a 0 on a PHQ, but everything else about them says there's probably a concern here. And so we really want our people to be very confident on the phone to do those. So they help in office, but if you were going to work a list for patients that are not coming in the office, if you're pretty seasoned and there's a lot of trust between the behavioral health provider and our behavioral health technician, then yeah, they can work together so that everybody feels like that's safe, because sometimes our technicians also feel a little bit nervous. What if I have someone on the phone and then they are positive, but I can't get someone right away? So there's just a lot of strategy around training and process and workflow.
That's great. Do you mind sharing what EMR, EHR you use?
We have Greenway Interg, and
Okay.
then our data monitoring is Azara.
Okay. How did the behavioral health providers adjust to this new process where they're seeing patients in the clinic and then also being asked to kind of call and follow up with patients? How did that go?
I would say it was a challenge. There was definitely people that um, had less buy-in up front, and then I think once you start doing it, it is sort of like, whew, this is time consuming, and it's really powerful. I think the biggest thing, I don't obviously know what your structures are, but we do have like a productivity expectation for we expect you to see this many patients in a week or on average. And so a lot of times with phone calls in between visits. I would say, I'm making up a statistic, but about half of the time nobody answers. And then the other half of the time that you get somebody, it's not going to be a telehealth encounter. You don't spend as much time on the phone things are going well. And so it's kind of like a quick checklist. So I think that was hard for people to be like, hey, I'm going to be spending all this time making phone calls without meeting productivity in doing that. But then I think when you do it, you really do see this really makes a big difference for patients. They're really grateful and they're really more engaged and they have better outcomes.
We have two more questions that are a little bit more specific to integrated health. So just, if anyone needs to jump off, these might not be as related to the UDS measure, but one is specifically around suicidal ideation. So if a patient were to screen positive on that last question for suicidal ideation, or they just mentioned something that's concerning, are those patients being connected immediately with behavioral health, or are the medical team sometimes having to take that on? What does that look like for you guys?
We try to never have a day where we don't have at least one behavioral health provider in each of our health centers. So really it's owned by behavioral health. And yes, that's an automatic referral. We don't want to let this patient walk out the door without connecting with behavioral health provider. Our workflow is if we have a positive question 9, we always do a Columbia suicide risk screener. Sometimes they're answering that question, it's really self-harm, which of course you still want to assess further, or maybe they're more passive thoughts. And so, your process for safety planning is going to look a little different. But there's some research to support universal safety planning with the current environment that we have. We don't do that. We don't do a Columbia on every single patient, but if they're answering question 9 positively, there's always a reason to ask more questions. So that is our workflow. Behavioral health provider is definitely connecting with them ASAP before they leave the office, and usually 99% of the time they're going to do a Columbia and a safety plan.
And that's usually the BH team that's doing the Columbia and safety plan.
Yes.
Okay. Similarly, what does the integrated team look like since you're not doing individual therapy, you're doing more brief interventions?
Yes. Yeah.
So like, how does that look on a day-to-day with how it works with the medical team?
We do focus on brief solution focused interventions. We sit on the team, so we have patients will be there for, probably I think our average is like 58 minutes. And so we do a quick check-in. Behavioral health provider will see a patient and a medical provider will see a patient. Sometimes that the two providers will overlap a little bit and we kind of give a live warm handoff with the patient there with an opportunity to kind of speak up if some of that wasn't handed off, in the way that we maybe misperceived what they were saying. So we don't see every single patient. So sometimes we may spend a little more time with a patient that needs behavioral health, and a medical provider can kind of see other patients in between. And the opposite would be true. Sometimes they get a little bit backed up with medical stuff, and then we can kind of move on and see patients with behavioral health needs. In our integrated team, we also offer dental, we have pharmacy, and we have clinical pharmacy as well that might pop in on a visit too.
Wow. Okay, so I think we have one more question and then we can let everyone go. In Ohio, are your services billable? Like, are you getting paid for your integrated services?
Yes, yes, behavioral health provider is a separate encounter.
Okay. Are you billing it as a um like a brief intervention, or is it like a short therapy session?
Yeah, brief intervention.
Brief intervention. Okay. Okay. Well, I saw you included your contact information in your slides, so I'm guessing you're okay if someone reaches out to you.
Absolutely.
So for now, we appreciate everyone joining this call. We intended it to be quick, so we didn't take up too much of your time. Just get to the point. Tracey, I really appreciate the information. I hope other people learned more about how you guys are having some success and maybe they can implement some of the things. But we don't have anything else for today, so we'll end the meeting. So thank you.
Thanks for your time. Good luck.